Happy Friday, everyone. Happy Friday. I am Larry Scott Walker. I'm the executive director and co-founder of Thrive Support Services. And I would like to welcome you to another Stronger Together conversation. Here we're talking about COVID-19 updates, facts, fears, and fatigue. Where are we now? Let us know where you are now as it relates to COVID-19. Next slide, please. Or do I have? This conversation is brought to us by Thera Technologies. Thera Technologies has sponsored the entire Stronger Together series, and we thank them. Shouts out to Thera Technologies. Next slide. And of course, as usual, the slides will be recorded and released to you on August the 26th. And don't forget to complete the evaluation for your chance to win a $100 Amazon gift card. Next slide. So today's agenda goes as such. We'll have a medical update from Dr. Chan. We'll have an emotional and mental well-being check-in with Damon Johnson today. Outside is open. I'll come back with some helpful tips as to how we engage outside, as well as some sexual health updates and practical advice for people living with HIV. And then we will open it up to your feedback, your questions, and things of that sort. Next slide. We like to ground the space by understanding that our shared vulnerability to this virus is our source of solidarity. We must remember that the virus, not the people living with COVID-19 or affected by COVID-19, are the enemy. The virus is the enemy, and that's from Valerie Earnshaw. Remember that and love on each other. Next slide. Without further ado, we will have Dr. Austin Chan, Assistant Professor of Infectious Diseases from Morehouse School of Medicine, to give us a medical update. Thank you all for being here.
All right, thanks so much, Larry. I'm glad to be back doing this series again. And so I'll be going through the medical update. It's kind of going to be a lot of different topics where we'll get into like a little bit, and I'll try to present the primary data as best I can. So, I won't be getting too in depth on any particular topic, but, certainly if there's more questions, we'll have more of these. And of course, you can certainly ask me some questions in the chat. All right, let's take it away. Next slide. So, the CDC has really put together a lot of nice infographics. Looking at the yellow circles there, that's kind of going through all of the conditions where you may be at increased risk from severe COVID-19 infection, including hospitalization and, unfortunately, also mortality. And so what we see there, starting over on the left, you got asthma, 1.5% chance of increased hospitalization, hypertension as well. Obesity, BMI greater than 30. And also what we see there, obesity pops up again with a BMI greater than 40. And so unfortunately, what we see is that if, unfortunately, as people, weigh more, as the obesity is more severe, that can possibly result in more severe disease. These conditions can be additive, so if you have something like diabetes and hypertension, that can result in a higher risk of hospitalization, higher risk of mortality. And of course, you see there are 3 or more conditions, 5 times the risk of hospitalization and mortality there. I think the guidance has very much stayed the same between Fauci, between the CDC. Outdoors is better. A little bit of space is better. Masks are good. Masks protect you and protect others. Obviously, depending on the type of mask, there's more protection for you. And additionally, prolonged indoor enclosed exposure with a lot of people is bad. And of course, hand hygiene, can be very, very effective. Always a good idea, no matter what. Next slide. So this is just kind of looking at the risk of hospitalization and death in different age groups. This is all well-known data, well-published. Essentially, children, are generally don't get as severe disease, generally aren't hospitalized, but it can definitely happen. There are certainly unfortunate cases of children passing away from COVID-19. Their rates are lower than the control population here, which is 18 to 29-year-olds. But, unfortunately, it is still definitely possible. As you get older, specifically once you start hit the 50s and 65s, there's a sharp increase in both hospitalization and mortality. There you can see, 65 and above, you just see very, very dramatic increases in mortality. And so, I would urge you to use these precautions to really, gauge your own level of risk and, the level of security that you need to maintain in quarantine. Next slide. And so last but not least, I think it's important to highlight the structural issues that affect different minority groups in the United States. What we've seen in different racial groups that, maybe are overall face challenging socioeconomic conditions, face poor access to healthcare, lower access to healthcare, and have higher rates of chronic illnesses, then we see this translates to higher numbers of cases, higher rates of hospitalization and death. We think of essential service workers as, people in the hospital, nurses, doctors, that kind of thing. But this includes truck drivers, grocery store people in the supply chain, people doing the mail. There's lots of lower income jobs that unfortunately they've just been treated incredibly poorly and not allowed to social distance. Their options are, do I get a paycheck, or, do I go unemployed and go homeless, or do I come to work, expose myself to this virus and get a paycheck? Social distancing may not be an option for some people. And I think all these factors put together have translated to, specific minority groups with higher rates of cases, higher rates of hospitalization, and higher rates of death. So I think it's important to bear in mind that COVID-19 is highlighting a lot of the health inequality within the United States. Next slide. So, going over the specific risk behaviors, the main points that I want to make here is, again, outside is better. Prolonged indoor contact with multiple people is bad. And, you can't always take a safe behavior and make it unsafe. But the flip side is you can take a risky behavior, and if you mitigate risk, then you can, get it somewhere where you need to. I talk about flying on an airplane because, sometimes this is unavoidable, right? Like, let's say you have to go to a doctor's appointment and you can't drive, and it's, in a different state, you're seeing a very specific specialist, and you have to get it on an airplane, like it's for cancer treatment or something. There are ways to mitigate your risk. I believe that your risks are that you can't control who you see. You can't control the different people that you encounter at the airport. You can't control who you sit next to on the airplane. But you can control whether or not you wear a mask. I would even, if you're very sick, I would urge you to wear an N95 if you can get one. But in general, flying on an airplane, I would consider a high risk activity, but there are ways to mitigate that. Eating in a restaurant, on the other hand, I would consider this to be more of a luxury, and I would consider it to be very, very high risk. Please just try to get takeout if you can. I certainly get a lot of takeout and delivery. I can't stand to eat my own cooking anymore. So I understand the urge, but, please do your best. Do your best. Next slide, please. So camping in the woods, on the other hand, is something that's fairly low risk, right? You can control who you're interacting with. You control who you're going to the campsite with. There's very few other people around. It's entirely outdoors. Yes, the person that you spend time in the tent with, or maybe sleep with in the tent, yes, you have very close contact with them. But, we're all kind of like quarantining with specific folks. Like, I can't socially distance from my family. I have 2 young children and, of course, my wife. And so we all just accept that we have, tied exposure together. Next slide. This one, I wanted to bring up the cookout again, just because there have been some outbreaks linked to small family gatherings. I think that what happens with these cookouts and barbecues, maybe there's some alcohol served, totally routine. But, precautions tend to get lax as things go on. You're with your family again. It feels normal. You don't want to wear a mask. You want to hug them, And so what ends up happening is that, those strict precautions, they kind of get bypassed. There's more slip ups. If you do want to have a cookout with people that you don't regularly, that you're not strictly quarantining with, I would say keep it outside as much as possible. Don't try to limit it to as few different families as possible. Really, just like one other family if you can. And know that if you're going inside, you should definitely be wearing a mask. I would encourage you to wear masks outside as well. Georgia's finally through the super hot streak, so it's not that uncomfortable anymore. But anytime you can wear the mask is good. Do your best to maintain social distancing when you can remember it. 6 feet's always a good rule of thumb. And then again, that inside time, like specifically in like choke points, like the bathroom or, like working in the kitchen, definitely want to be wearing a mask for those times. Next slide. So this is something I wanted to bring up. It was definitely a hot topic last time. This was the detection of SARS-CoV-2 DNA in semen. So I wanted to bring the study initially that caused all the news. And so highlighting this here, this was kind of a pretty small study. It was 38 folks total. And what they found at the end of the day was that there were 2 people who had recovered from infection who still had detectable levels of virus in the semen. Now, is this simply non-infectious viral DNA? Is this true infectious virus that could cause infection? We don't know. To date, I tried to find some cases of sexually transmitted SARS-CoV-2. I could not find any specific cases for that. And there were 2 other studies that I did want to show you here. Next slide. So looking at this, these were 2 studies where these are very small. Again, this is like 20, 30 people, but what they found was that of these 2 cohorts, none of the people had detectable viral particles in their semen at 30 days. I don't know how to give any guidance about this. I haven't seen any particular guidance, from WHO or CDC. I haven't seen a particular case report where SARS-CoV-2 is sexually transmitted. I don't want to stray too far and make any proclamations, but I think in general, if someone does have SARS-CoV-2 and they recover, they wait their appropriate period, their nasopharynx is no longer testing positive for virus, that I think should be still an appropriate time frame to wait, before seeing them again and doing other things, sexual or otherwise. Next slide. So just wanted to say something that we experienced here in Georgia. We had a bit of a surge, specifically in July. At Grady in particular, where I work, there was a case positivity rate of as high as 20%. That was something that we hadn't seen since back in April. And unfortunately, because of the increase in being test requested, the increase in interest in being tested because of all these concerns for exposures, there was a huge testing backlog in our area. And so the tests really took a long time to come back. And I just want to, say we really need to continue to expand our testing. The more cases we have, the more testing we need. We can't do effective contact tracing without testing. And, we still, as a country, I think we need to continue to expand our testing capacity. We need to figure out a way to have the state labs collaborating. So if one state is overwhelmed, we can send it to other places. I think there's a lot of considerations for testing, but in general, please more and please faster. If you can't get a test result for 7 days, essentially you have to just behave as though you have COVID-19. You can't do anything for that time until your test gets back. So, I think it's very challenging. Next slide. All right, so of course this is Stronger Together, and we should definitely specifically look at folks with HIV. There were a couple other case series, a Turkish series by Aydin, I believe. This is another case series again by Harder. This was pretty small, I think it was about 32 folks total. Overall, the general message from both WHO and CDC is that people living with HIV do not have increased risk for severe infection from COVID-19. The other risk, now we do know that, diseases of aging, diabetes, hypertension, obesity, these are certainly affect people living with HIV, but those are probably stronger indicators and risk factors than HIV. Now, the caveat is if you are someone who has a CD4 less than 200, less than 100, that may put you at increased risk. We're not sure. In this particular case series, we saw a patient present, with very late stage HIV. Their CD4 was 69, and they had an uncontrolled viral load. That patient unfortunately passed away. And so, I think that goes along with our guidance that lower CD4 may put you at higher risk. We don't know, but I think that it's very reasonable to say you should take extra precautions if you fall into that group, or you have patients that fall into that category. Next slide. So another thing that I wanted to bring up is the morbidity associated with COVID-19. We often talk about deaths, like this is the death count, follow the death count, how does that look? And, that makes me depressed. That's super depressing. This is even more depressing. This was a study done, published in JAMA, looking at the people in Italy who ended up with, who had COVID-19. And what they found was that after the hospital stay, even 60 days post-hospitalization, you had 50% of people experiencing ongoing chronic fatigue. You had about 40% of people still experiencing dyspnea, 20 to 25% with joint pain, on and on down the list. And so what we're learning about this disease is that it's not just over when you get through the acute phase. Thankfully you didn't die. I certainly don't want to die of COVID-19, but if you contract it, there is still this hidden risk that nobody's reporting. Nobody's reporting on the morbidity and the follow-up symptoms that you have. And so I think it's important to bear this in mind. It's not just like, oh, I have a 0.1 chance of dying, I'm good to go. It's like you may have a very high risk of getting chronic fatigue from this. You may end up on dialysis, other issues. And so these are all the things that can affect patients with COVID-19. Next slide. So, as we go into testing, I'm sure a lot of you guys have a lot of familiarity with testing with respect to, the HIV world. Just wanted to briefly go over the terms sensitivity and specificity. Sensitivity is for screening tests. The idea behind sensitivity is if something is 100% sensitive, it means that everybody with the disease will test positive. So you don't want any false negatives. An example would be someone who has HIV, but the test is negative. That would mean that there's decreased sensitivity of that test. The flip side is specificity. If the test is positive, that means they have the disease. And so briefly, if someone has a positive test for HIV and it's 100% specific, that means that person has HIV. If it's 90% specific, that means 10% of the time the test will be positive, but the person will not have HIV. So I know it takes me a lot to wrap my head around it. I still struggle with this even since medical school, but we'll come back to it. These are just kind of the core concepts behind testing. Next slide. So when you are thinking of designing like the perfect diagnostic test, it's cheap, it's easy to administer, potentially you could get it at home, it's not invasive, it doesn't hurt, and the results come back quickly. In addition to that, ideally it would be 100% sensitive, meaning every person who has the disease will test positive, and it would be 100% specific, meaning every person who tests positive has a disease. Let's say a test is has a 1% sensitive or 99% sensitive. When you expand those numbers to like a nation, like the United States, that means we're missing, and you consider our population is 330 million. If there's a 1% decrease in sensitivity, that ends up translating to like 3 million people who have the wrong diagnosis, who have the disease, who don't know they have it. And so our goal here with these diagnostic tests is to get them as good as possible, or at least develop a testing protocol so that, we don't miss those people on the margins who can definitely cause problems, especially with such a contagious disease as COVID-19. Next slide. So this is just going through all the different testing modalities. There are just there's way too many specific tests for me to keep up with them all. I don't want to put my foot in my mouth or say anything wrong. But speaking in general, these are the different kinds of tests that are available. So you've got the molecular test. This is going to be the nucleic acid amplification, very similar to the HIV viral load. This is the nasopharyngeal swab. They extract the nuclear material and they run it as a PCR. And if you amplify, then, that's a positive test. The antigen test, this is one looking for not viral particles that are non-DNA, like proteins and stuff. These are generally pretty quick, and they're cheaper than the molecular tests. But sometimes there are some of them that have been reported to have decreased sensitivity. So the person may be positive, but the test may be negative. These are the kinds of tests that are being deployed for like a lot of the sports leagues that are coming back. So just something to keep in mind between the molecular test and the antigen test. So if someone says to you rapid test, I couldn't tell you what that means. That could be a fast molecular test. Those exist. It could also be a fast antigen test. I think it's worth investigating what they mean when they say rapid test. Rapid test is just like, I want my results back in 24 hours. Is there a rapid test? But just get a little bit more specific, because that doesn't give me enough info. Last but not least is the antibody test. This is the serology, looking at the antibodies made to COVID-19. There's a lot of different platforms out there with high variability. In general, you have to wait a couple weeks. You may even need a second test to see to make sure it's truly negative or positive. We'll get into immunity a little bit more later, but I think this is really for epidemiological purposes, to model disease rates and all that kind of thing. Next slide. So last but not least is the COVID tracker data. I'm sure we've all seen these curves, new tests, new cases, how many people in the hospital, how many new deaths per day. I think that I would urge you to not read too much into these. The reality is that we have uncontrolled community spread in the vast majority of communities and states across the United States. As I've said before, this is both a national and global pandemic, but it's also intensely local and very specific. In a country like New Zealand, where they have no community spread, they're in like a contact tracing phase where there's essentially very, very, very few cases. Outbreaks are like 30 people outbreaks. Hey, you could definitely follow these curves closely. Are things getting better? Things getting worse? But in general, for the United States, you can't use these graphs to really inform your risk. We still, for example, in Atlanta, we just still have widespread community spread. I would definitely wear a mask. I would still continue to quarantine. And so, and it's up to, the individual state governments to go ahead and say, we no longer have community spread in X state. We no longer have community spread in X area. Maybe we can relax precautions in that way. So I just wanted to make sure that we're interpreting this data correctly. This is not clean, processed, clinical studies data. This is like raw data. It's very helpful. It's very good. I'm very, very glad they did it, but it's important to use it in an appropriate way and not draw too many conclusions from it. Next slide. So just wanted to briefly, everyone who talks to me say I'm too depressing about this. So just wanted to give some really good news. We do have some therapies that work. Absolutely. This is the recovery trial through the Recovery Collaborative Group looking at dexamethasone in hospitalized patients. There you see the mortality survival curves. Dexamethasone is in red, placebo or nothing, usual care is in black. And what we see is that patients who require oxygen and who receive Dex definitely have improved mortality, no question, probably about 12 to 13% improved mortality. And so, dexamethasone is a drug that we know very well. We've used it for a very long time. Yes, there are side effects, but the overall safety profile of steroids is incredibly well known. And so steroids, plus remdesivir, hopefully when we see the final remdesivir data, we'll have a better sense of the mortality improvement there. But there's no question that that these drugs can save lives with respect to COVID-19. Next slide. So this is a hot topic. Damon wanted me to discuss this. I don't want to stray too far, so I'm gonna try to stay in my lane as an ID doc here. This is a case report of possible novel coronavirus 2019 reinfection. I want to walk you through it because there's a lot of caveats to this, and the author, Dr. Dugan, acknowledges those in the article itself. So what we had here was an 82-year-old male with diabetes, Parkinson's, CKD, presenting with severe COVID-19. He was hospitalized for 39 days his initial visit. I believe remdesivir was not available at the time. They did not address whether or not he received that medication. But he recovered, eventually was discharged to a rehab facility, on day 39. So essentially, he probably had the disease for about 46 days at that point, just ballpark. Patient returned 10 days later, so this puts him at 56 days. He had fever and hypoxia. CT scan demonstrated bilateral GGOs and also consolidation with possible bacterial pneumonia. Patient received antibiotics. Cultures did not grow an organism that was, that we typically think of as causing pneumonia. RT-PCR at time of admission was still positive. So that's one of the things when I say possible case. Eventually, he recovered, transferred to medical floors on day 7. RT-PCR was negative on days 11 and 12. So it's kind of like 60-ish, 70 days, after his initial hospitalization. And what I'll say is this, you would have to prove to me that this guy didn't have recurrent bacterial pneumonia and that it wasn't just lingering, viral shedding. What we've seen is that this virus can shed for a very, very long period of time. The initial concern over reinfection came from studies in Korea where they tested people's noses, 30 and 60 days. They did nasopharyngeal PCRs 30 and 60 days after infection, and they were still positive. So they were wondering, is this just ongoing shedding? That's crazy. Or is this reinfection? They couldn't say. There's an immunological consensus that we hope we hope that immunity, you can develop immunity to coronavirus 19, hopefully. We don't know how long that immunity lasts. Certainly there may be a subset of the population who could get reinfected. There's a lot of caveats, but I'm hoping, please, in general, that most people can develop some kind of lasting immunity to this. Does this mean that you can, go totally nuts and break quarantine and all that stuff? I certainly wouldn't recommend that. That also sends a strange message, but I want to be hopeful. And so, I have not yet seen a true definitive case report of reinfection yet. I will definitely keep an eye out for that for you guys. Next slide, please. So last but not least, we're just going over the vaccine candidates here. This is, please, hopefully we get a vaccine very soon. These are, just the ones that are farthest along in their development. So they're in the phase 3 they're in the phase 3 part. So phase 1 is first in human, it's like small, like 12 people. Phase 2 is kind of looking at efficacy, a little bit larger, looking at side effects. And then phase 3 is like the big, real world study, trying to suss out like rare side effects and all that stuff. So you got the Oxford studies, the AstraZeneca vaccine, that's the combo. This is an adenoviral vector. Moderna is the big one in the United States. They're in phase 3. Their phase 3 opened like a week ago. We're a site here at Grady. This is an RNA-based vaccine. Novavax is coming up soon. Sanofi, Janssen. Janssen is an adenovirus. Novavax is, protein subunit. There's a couple Chinese vaccines that are inactivated virus. So, there are tons of vaccine candidates out there. They're all coming into phase 3, and I really hope they work. I think the big questions surrounding the vaccine are again, how long does this immunity last? That's the biggest question. Are we going to have to vaccinate people 2 or 3 times before we really get this pandemic under control? We're not sure. Hopefully the answer is only one, but it certainly remains to be seen. And just to give you a sense, this vaccine development has been light speed. When you look at all the other vaccines, Menactra, PCV13, Pneumovax, Prevnar, all those guys, these typically took 4 to 6 years, 7 years, 5 to 10 almost, in terms of development. But what we've seen with COVID-19 now they're moving into phase 3. Generally, the FDA wants to see 2 years of phase 3 data before they, say a vaccine is totally safe. The question is going to be, as we get into the winter, how quickly will they pull the trigger on widespread vaccine approval? How much phase 3 data are they going to want? 3 months, 4 months, 5 months, that kind of starts to put us in November, December. So that's something to very much keep an eye on. But next slide, that about does it for me. Please let me know if you guys have more questions. I'll definitely be around for the Q&A session there. So I'll turn it back over to Larry and Damon.
Thank you so much, Dr. Chan. That was a great wealth of information. I especially love how you humanize the other frontline workers and essential workers and gave us practical advice around, or practical information around semen transmission and things like that. What stuck out for you? Put into the chat box what parts of Dr. Chan's presentation stuck out for you, if you had any questions or anything like that. And just check in with us as to how you feel and what's going on with you. We'll see you in about 90 seconds.
Good afternoon, everyone. This is Marcilla, one of the team members from Georgia AETC, and I would just like to take a moment to share a few announcements with you. Keep us up to date on your interests by completing our training survey. Let us know what training topics you would like to hear by clicking the link in the chat box. You can submit a request for sponsorship, support group presentations, and more. We are simply here to support. If you need any information regarding virtual support, new therapies, and/or any other vital information, contact us and we can get you connected and assist you in staying connected. We are in this together because we are truly stronger together. Just a reminder that the presentation is being recorded and the slides and recording will be shared with everyone on Wednesday, August 26th.
With that, I would like to introduce my colleague and Morehouse brother, Damon Johnson, program manager from Georgia's AETC, to speak on the emotional and mental wellness aspects of COVID-19. Welcome, Damon.
Good afternoon, everyone. Next slide, please. So today I'm going to talk to you guys a little bit about the mental health and emotional well-being of individuals during the time of COVID. But I thought it was important to differentiate mental health and well-being because oftentimes we kind of use those terms interchangeably and we feel like they one impacts the other one or inversely. But what I wanted to say is that mental health is a positive concept that includes or encompasses your well-being, both the social and emotional well-being, and is not merely the absence of illness. And I think oftentimes we feel like when we say mental health, especially in the Black community, we think about someone's being crazy or someone's loose. There's a very stigmatizing tone that surrounds mental health. But I wanted to kind of let people know what exactly it was and how it affects individuals on an individual level. So we know that it affects how we think and we feel, and it determines how we handle stress and relate to others and make choices. So I think that was important to highlight. And as we go throughout the presentation, we'll talk a little bit more about it. Next slide. Well-being is described as a state of being healthy, happy, and prosperous. And I think this is something that we all desire, especially during a time like this. So there are 8 dimensions of wellness. We have intellectual, emotional, physical, social, occupational, financial, environmental, and spiritual. And I think we can all agree that being well on each of those levels are important to our overall well-being and our overall state of happiness. So I think looking at this, it integrates both our mental and physical health because, as I always say, there's no health without mental health. I believe everything starts mentally. So if we can make sure that our mental health is optimized and that then our well-being in turn will be optimized, and then we'll be our best physical selves. So I think it's important to kind of understand both of these during this time of social disruption or social distress. And like I said, this will be the foundation from where we speak from. So next slide. So I think it's important also to normalize how we may be feeling during a time like this so that individuals on the call know that we are not alone. So I think stress, anxiousness, powerlessness, isolation, loneliness, depression, changes in our sleeping and our eating habits, all of those things are real. And especially this bullet with changes in sleeping and eating patterns. I think it's so important to understand that while many of us may be working from home and or spending more time with individuals that we're around, I think our schedules are all off as a whole. So I think it's important to understand that this is normal and you're not alone, that there's a level of loss and grief because there are people who are having budget cuts at jobs and people are being laid off. Children are going back to school. Now they're not going back to school. If you're in college, or your campus may be open on one day, closed on the next day. So I think it's important for us to understand and normalize these feelings so that we are all so that we understand that we're all in this together. And so let's kind of keep this in mind and let's be okay to feel and give yourself permission to feel. Next slide. I think it's important as well to touch on social distancing and understand that it does not mean that it only means physical distancing and not isolation. Maintaining human social connection is important. We all know that social connections makes us happier as humans. It makes us smarter and we're more productive when we're around others. But so I believe it's important to understand that social distancing does not mean physically physically isolating yourself from everyone and everything. We still have to figure out how do we normalize or create COVID bubbles of people that we're around, either our roommates and people that we're safe, that we know their whereabouts, that we can pinpoint where they've been, how they've been, if they've been tested, if they're truly negative. Some of those things where we have control variables, but also just understanding that human connection is so important to our mental and our physical health and that our emotional well-being is impacted when we don't have those social connections. So it's really important for us to really maintain a level of social connection during times like this. And I know many of you may say, how? So we have to understand that there are so many different things that we can do now to maintain this social connection, such as FaceTiming. Me and my family use this thing called House Party. It's an app that we download and we get on it once a week just so that we can all touch bases with one another, laugh, play games, and joke around. But also text messaging, social media, these are all things that can kind of increase that social connection and keep us in a good mental health, in a good mental space as well as an emotional space. Next slide. So again, I just gave you guys some tips on coping and managing stress and how it impacts our well-being, but connecting with your friends and family, as I stated, practicing mindfulness, and we'll talk a little bit about that on the next slide and talk about what is mindfulness, but also meditating, taking breaks from watching, reading, and or listening to the news. That's something that I struggled with, because when this first started, the immediacy of it, the immediacy of the threat was so real for me. So I oftentimes was so afraid of just getting anything. So for like 61 days, I did not leave my house and go to the elevator. Groceries were being delivered and everything. But what I had to realize is I had to create a balance for myself. But eating healthy and well-balanced meals, avoiding alcohol and drug use. And I know many of us are probably saying, well, how do you tell adults to do this? But I think it's important for us to really understand that if we're home and we're around certain things more and more, we have a tendency of utilizing those things. So it's important to pay attention to our alcohol and drug intake during times like this, so that we can maintain a healthy balance and approach it from a space of moderation. Getting plenty of rest and doing things that help you relax. So I think finding those things, so reading, if you are a person that likes to do crossword puzzles, creating a new hobby for yourself. I think all of those things are important. So figuring out what it is that makes you happy, or what it is that kind of centers and grounds you, and really working on those things during this time can kind of help us cope with the stress and the undue stress during these times. Next slide. Again, we just talked about mindfulness. Here is a mindfulness exercise. And when you guys get the slides, I won't take up too much time going through it now. It's a mindfulness exercise that I adapted during this time, because I was never really big on the whole meditation and all these things. And my grandmother actually sent me this mindfulness exercise, so I decided to share it with you all. But it's something that really helps centers me. It helps me focus. It helps me really, really, really gather myself and really put things into perspective. And I think this is something that's so vital during a time like this, because there's so many thoughts that can be going on, or so many things that can be going through our minds during a time like this. Do I send my child back to school? Do I go back to work and risk my life? Do I go to the grocery store? How is this going to work? What is going to come up tomorrow? What's going to be new? So I think it's really important for us to center ourselves a few times throughout the day, so that we can really pay attention and be in close contact with who you are and the things that may be worrying you and or stressing you, so that you can confront those things head on. So here's a mindfulness exercise. Please try it, and I hope you enjoy it as much as I do. Next slide. Here's a quote: being able to maintain social distancing while working from home, telecommuting, and accepting a furlough from work, but indulging in a plethora of virtual social events, are issues of privilege. In certain communities, these privileges are not simply accessible, thus considered the aggregate of higher burden of at-risk comorbidities, of adverse social determinants of health, and the absence of privilege. So one of these, what this does is, we talked about ways to maintain social connections during a time like this. And oftentimes I thought it was important to put this quote in here, because oftentimes we forget our privilege. And there are many people that we serve, and there are many people that are probably on this call that are a part of communities that may not have access to some of these things, such as Zoom or our phone that can download House Party apps. So I think it's important to understand, before we cast judgment on individuals, to understand that everyone may not have the same luxuries that we have, and trying to maintain social connection during a time like this. Instead of us condemning it, they're missing their family, they're missing their friends, they're missing those connections just like we are, but they may not have access to the resources that can kind of connect them virtually. So I think it's very important to understand that if a person comes back with COVID, or if you see a person on social media with their family, before you cast judgment, remember that there may be a level of privilege that exists that may not be afforded to them. Next slide. caution fatigue. I think we're all, or many of us are about here. But I wanted to remind you that this is a natural response. However, we still have to figure out ways to mitigate our risk and mitigate community spread and being a role in that. Next slide. The immediacy, like I said earlier, the immediacy of the threat, anxiety about the unknown, and intensity of fear led to compliance and safety measures when this first started. So when this first started, we were all kind of afraid of the unknown. We didn't know what was going to happen. But as more information comes available to us and more ways to prevent ourselves, or information, or changes in contagion information changes, what you'll find is that our risk perception kind of minimizes, it decreases. We kind of feel like, okay, you know what? Maybe this is not as bad as I think. Or if you know someone that had it and you feel like, okay, well, I didn't get it, but my best friend had it and we were around each other. Maybe I'm immune. Maybe I'm one of those people that can't get it. So all these things kind of make us kind of feel like, okay, well, maybe I can kind of ease off some of the caution. But anxiety and depression increase stress. Taking in information in isolation can exacerbate the emotional reaction. So that kind of made us at the beginning say, no, I'm not doing anything, kind of like I was in the house for 61 days. But as threat extends, the brain system lowers that level of threat and it reduces that stress. So again, we start minimizing our own personal risk. We start feeling like, okay, well, you know what, now as I was afraid to go to the grocery store on day 16, now day 83, I'm not as afraid. So I'm going to go to the grocery store. I'm going to wear my mask. I'm not going to put on my hazmat suit. I'm just going to go out here and I'm going to do what I need to do because I know so many people doing it. So again, understand that caution fatigue is real. However, we must still practice certain things and we must determine what it is, what's going to work for us, and what is going to be the cost and benefit for us when we take certain chances. Next slide. And we see this to be true. Caution fatigue is real here in Georgia. Well, specifically Atlanta, we see, well, in Georgia, this study specifically talks about how they track cell phone usage, and they saw an increase of travelers that were crossing over the Georgia state line. And this was a few weeks ago. This was May through June, a few months ago. Actually, we're in August now. However, what I'll say is that we're seeing more and more people come in town in Atlanta on a day-to-day basis. I have friends, I have sisters, and we see this in our data as well, that there are so many people that are flocking to areas that are open. And as your states and cities open, you'll find that more people are there. There'll be an increase in movement. So we must still practice or figure out what is going to be our safety mitigations or our safety habits that are kind of keep us protected, us and our family protected from COVID-19, because it's still real. The threat is still real. Next slide. Again, changes in contagion information is real. There's been so many changes from the start to now, and I want to normalize this as well. I want us to remember that this is normal. As we do more research, as research becomes more available and more widely accessible, what you'll find is that things will change. However, it's not to say that this person was lying early on, or this person didn't know what they were talking about, so I should just dismiss them. We have to understand the role of research and everything that's going on. And we have to be mindful that, hey, while they did say surfaces early on, you can kind of catch it from surfaces. Now you can't. Research made this information available. So the uncertainty about being the safe distance, some people said 6 feet, some people said 16. So finding reliable sources and finding and doing your own independent research is going to be so vital during a time like this, because this can all impact our perception of risk and also impact how we behave and how we act as a result of how we feel. Next slide. So again, changes in risk perception is so vital to compliance. And we know this to be true even when we think about HIV or putting yourself at risk for HIV. Now, I laughed, I saw a meme the other day. There are so many people who will wear a mask, but we won't wear a condom to protect ourselves from HIV. And it kind of laughed, but it plays back to this whole perception of risk thing. Again, feelings of loneliness and isolation increased in mid to late April. So if you think about it, people are lonely. People are like, okay, you know what? This is too much for me. This is beginning to be burdensome. So now there has been a shift where people have started from this whole, okay, well, I'm not doing anything. I'm just going to stay in my house. I'm not going to talk to nobody. I'm not going to go see my mom, my grandmother. People are missing and longing that personal connection. So what you'll find is that people are starting to minimize their risk because they may see, well, my sister has been around my mom, so maybe I should, because my sister and my mom are both good. And we see this, like I said, even in our field. So I think it's really important to understand that changes in information can lead to a change in risk perception, and that can alter our compliance as a whole. But also this movement from shelter at home to safer at home measures. So when you think about this as well, okay, well, if our leaders are saying that it's okay for us to do these things, then hey, maybe it's not so bad. So I think all of this kind of plays into how we assess risk and how we perceive our own level of risk and how compliant we are to certain things. But holidays and increased relaxation, we just had the 4th of July, we had Memorial Day, we're approaching Labor Day. And these are days and holidays that we're used to being around people. I know Black Gay Pride is coming up, and now I'm thinking to myself daily, like, what is this going to be like for individuals a part of the Black gay community? How are they going to convene, and how are they going to participate? And this is something they look forward to. And now that we're quote unquote at the tail end of the virus, for some people, what is this going to look like? So I think it's important to understand that changes in risk perception can alter how compliant individuals are. In school, which is a hot topic at this time, deciding whether or not to send your child to school or to return to school yourself is so important. So I think we have to understand that human nature is to maximize gratification and to minimize deprivation. And so a lot of us are feeling deprived of things. So naturally, we're going to move to that other end of the spectrum. Next slide. Returning to employment and daily life, making safer choices. So I know we talked a lot about what can now change our perception of risk, what factors play a role in that, and how we kind of respond. But now this portion, we're going to talk about some of the things that can help us make safer choices so that we can independently make choices that maximize that gratification to us and minimize the deprivation, but still do it in a way that's most safest for us and us defining that, and it's not being defined by someone else. Next slide. So the reality for essential workers is that they've been at work. They never had the luxury that we had to stay away from home. Police officers, firefighters, nurses, doctors, and people that work in these industries, pharmacists. But not only these people, but the people that work at the grocery stores, our neighborhood Targets, our neighborhood Walmarts. These are people that never had the luxury to kind of say, I'm going to work from home, I'm going to do this from home. So the reality for them is that, hey, they face their own level of fears. Their families have faced an enormous amount of stress, and their emotional needs and their family needs have all been different from us. So I want to lift them up during a time like this. And as they had to develop personal plans of actions to kind of protect themselves and their family and their loved ones, we now have to do the same thing as things kind of shift. And there are many companies that are making the decision to either let their employees continue working from home, or B, moving back to things as normal. So now this is going to be really important, but I want to lift up those workers who this has been their reality since the beginning of the pandemic. Next slide. So as of Thursday, there were 173,514 deaths. And I want to take a moment before we start making our own personal decisions, our own personal safety protocols, to kind of keep these people in mind so that we can understand that we have a role in community spread, and that it's our job to kind of figure out what can we do to kind of act as a counterforce, but also understand that this is real and that people have lost their lives. So we'll take a 10-second moment of silence for those people. Thank you. Next slide. So the call comes, we're opening back up. What are everyone use the chat box. Let us know what were some of the feelings that came up when you got the call, if you've gotten the call, that your job is opening back up and now you're having to return to work. Or if you haven't got that call, what are you going to do when you get that call or that email that say, hey, it's time for us to return to the office? How do you believe that you will act? What questions will arise and what feelings come up? So a few people drop us a line in the chat box and let us know. And Mercy, we'll go to the next slide while they do that, and we'll kind of talk through some things. So negotiating safety in an unsure world, I think this is so real. What you have to do is you have to determine your absolute. What things are you absolutely not willing to give in on? You have to weigh your risk, establish an acceptable level of risk for yourself, and then weigh the cost and the benefit. So I think it's so important to understand that this is going to be that negotiation process or cycle that you're going to go through when making decisions. And these are the things that we go through as an individual when we make decisions on our own. But as we negotiate this, we must be sure that we all are really looking forward to returning to this whole sense of normalcy, but we have a safety negotiation thing in place. So determine your absolute, weigh your risk, establish an acceptable level of risk, and weigh the cost and benefit. So for me, I know that I absolutely do not want to pass this on to my grandparents. So when I'm returning home, I always get a test prior to going home so that I test negative. I weigh my risk. If I go home and my grandparents get COVID-19, what is that going to look like? But I also have to determine if I'm going to see other family members, if I'm going to go around friends, how often am I going to see them? Then I have to establish that level of risk. Well, I don't want to go around this person because I know they're doing this, they're doing that. So then I weigh the benefits. So if I go home, it's like, okay, you know what? I want to see my grandparents. So it may be one of those things where I have to lock myself in with them an entire weekend. So I think it's so important to understand that you have to negotiate your safety in this unsure world, and you have to make some determinations on your own because there's so many variables that play into this, and we have to figure out what's going to work best for us. Next slide. Continue protective measures. These things have not changed. Wearing masks is still recommended, and we know that this is effective and mask work. However, there are different regulations and there are different mandates in different parts of the city, your state, your localities. However, we do know that mask works. Social distancing works. Limiting crowd size. Dr. Chan talked a lot about this earlier. Hand hygiene is very important, and limiting the actual excess of touching your face and other parts of your body that can kind of make us infectious. So these are some of the continued protective measures. These things have not changed, and I think it's important that we kind of, as we're creating our own risk reduction plan, that we keep some of these things in our toolbox. Next slide. So there are questions that still remain, and I think it's very important for us to understand that these things are normal as well. So we're still figuring out, or some people still feel like, I don't know when I should wear a mask and when I shouldn't wear a mask. Some restaurants let me in without a mask. Some places I need a mask. When is it social distancing not necessary? So if I'm in a house with people, do I have to social distance, or what is that? What is or isn't okay? So what crowd size is okay? In our schools safe? So I think it's important for us to understand these questions are normal. So again, that goes back to understanding and creating and going through your own risk reduction process and negotiation, safety negotiation process is going to be really important, and consulting with certain people that you feel like that are trusted individuals, healthcare providers, and individuals that truly have a knowledge or who are abreast, or using times like this to ask questions that you may not know the answer to a panel of experts. Next slide. To parents and children, and this is my last slide, I think this is so important to uplift right now. This is one of the most difficult decisions for a lot of people, especially parents, aunts, and or caregivers. But it's important for us to understand that children have their own reactions, because now we have abruptly or drastically gone into this new space right now, and children are kind of confused, like what's going on. We went from February not having to wear a mask, and now we're telling children you have to wear masks sitting in your classroom. So understand that children are going to have their own reactions, and they may need more attention and emotional connection during a time like this, because their world has been rocked just like a lot of ours, but their processing and their comprehension of this may not be the same as ours. So find positive ways to express their feelings, and you have to give them a space to do that. But if you do not know, I think it's important to contact your healthcare provider and or behavioral health professional if you're concerned about your child's well-being, but also contacting other parents and creating support groups and support networks to figure out how are other parents dealing with this, how are parents coping with this, and how is this new norm, how do we explain this to our children? This is a book, Bravery Conquers the Coronavirus, The Adventures of Bravery, and I think it's a great book and a great read for parents to kind of understand from a child's perspective what children may be going through during this time. So again, parents and children and caregivers just in general, I think that it's very important for us to understand that this is an uncertain time for all, but especially for the little ones and people that we are guardians over. Next slide. The safer sex analogy is so important. I think it's important for us when we're creating our own risk reduction plan of actions to kind of use this, and we're all familiar with this, or most of us are familiar with this. So, do I know my status? Again, this is kind of what I go through. Do I determine the partner status and relevant history of others that I'm going to be around? But gathering information and weighing the relative risk. I think developing standing guidelines, saying I'm not going to do this, I am going to do this. Staying abreast of my status and other status is important. So routine testing is going to be important with COVID-19 as well. When things change with you, just kind of like even when your sex life, when things change, it's maybe time for you to update yourself on where do you stand. So again, these are some of the things. And I know this says don't get drunk and lose your head, but again, understanding that it's everything in moderation during times like this. And the next and final slide, Larry. The scourge of COVID-19 will end, but healthcare disparities will persist. Thus, the U.S. chronicled these poor outcomes due to COVID-19 complications with the higher burden of cardiovascular disease, poor outcomes for breast cancer, higher amputation rates for peripheral vascular disease, lower kidney transplant rates, and worse rates of maternal mortality. Then safely park everything in the healthcare disparity domain and go back to normal. Or will the nation finally hear this familiar refrain, think differently, and declare that a civil society will no longer accept disproportionate suffering? Yancey 2020. Thank you all, and I look forward to your questions.
Thank you so much for that masterful presentation. Thank you for holding up that we are all experiencing a collective trauma right now and giving us a way to mitigate that. So I invite you during this break to breathe and do a bit of the centering exercise that Damon spoke of. We'll talk to you shortly.
Greetings, everyone. This is Evan Pitts, one of the members from the Georgia AETC team, and I'd like to share a few things with you. Do you have any upcoming virtual community events or meetings? If so, what kind of support do you need? Please share the date and time of the event or meeting in the chat box, or you can send a direct message to the host and/or panelists for specific support needs. To reiterate that, Georgia AETC is simply here to support. If you need information regarding virtual assistance, new therapies, and/or any other vital information, contact us. We can get you connected and assist you in staying connected. We are in this together and truly stronger together. And finally, be on the lookout for our session evaluation. The link will be posted in the chat box towards the end of today's presentation. We rely on your feedback to help guide our content and our efforts, so don't hold back. Thank you.
Thank you so much for that update, Evan, and welcome back, everyone. I hope you are nice and centered and in your Zen space. We are talking about how to re-engage outside for those for whom outside is just opening. If you're in Georgia, outside closed for like a day and then opened right back up. So, but we're going to talk about how we can practically and realistically engage with outside. We're going to go to the next slide. So don't believe the hype. Coronavirus is still very real and very, like, as Damon said, things are still, happening. And of course we have to get back to some sort of normal, but I want us to listen to the advice and the information that came in Dr. Chan's presentation and not just believe the hype. Just because a place is open doesn't mean that it's safe for you to, go in. Doesn't mean just because everybody is having fun and, taking selfies, 10-person selfies with no mask and things like that, doesn't necessarily indicate that it's safe for you to do or that it will be healthy for your life. Next slide. So again, in not believing the hype, here are some numbers. These are from within the last week. Actually, I just got these numbers, and a lot of the places that are open, like Georgia, look at the numbers of cases within the last 7 days. 17,000 people contracting coronavirus is antithetical to what I would think safe would be. So we have to embody our own safety measures, and like Damon said, to weigh our risk and make a plan for our own lives. And a plan of action is very essential when we're trying to keep ourselves as well as our communities and our families and loved ones safe. Next slide. Here are the CDC guidelines for gatherings. A gathering refers to a planned or spontaneous event, indoors or outdoors. Like, so if you at the park outside, following Dr. Chan's suggestions, and 8 of your friends decide to join you, and you're all like gathered in a space, that is a gathering. It doesn't have to be planned. It could be spontaneous. And the more people or individuals that interact in a gathering, or the longer that we interact in close quarters, the greater our risk is. Understanding that and using that to inform how we re-engage with the space, and then understanding that higher level of community transmission in areas. So for Atlanta, Fulton County is has a higher prevalence of COVID. So that's an area that we need to be engaging all the most strict, the most strict practices to keep ourselves safe. Know the risk level in the area that you're going to. And then, of course, assessing the size of the event. If it's an outside event, and you're going to be wearing your mask and things like that, and we're going to be physically distancing, but there's like 100 people that are coming to the event, then that kind of changes the game a little bit. So like really asking these questions and assessing, making a proper assessment for yourself, something that you can be comfortable with, because you're trying to keep yourself safe and not contract or spread the coronavirus. Next slide. Again, this is the risk level or of venue, based on venue or an engagement for spreading coronavirus. You see, of course, virtual events like this one, no risk or very low risk, or the lowest risk of spreading coronavirus. But then it goes up when we do things like go outside. If we're outside and there are other people outside, of course, there's some risk, but we're in an open space, so it's more risk, but less risky still. When we're in medium-sized in-person gatherings, when we do things like go inside of a restaurant, go inside of an office, go inside of a school, those are higher risk. And the highest risk is being in large in-person gatherings where it's difficult for you to remain physically distant, or you're inside of a space and there's a lot of people in there. That's more risk. So knowing these risks can help us to, make the best decisions for our lives. And like Damon was saying earlier, just a second ago, that to properly assess our risk, to properly plan for how we engage, or if we engage even. On the next slide, you'll see that Georgia was named the place that you'd most likely be exposed to the coronavirus. Yay, Georgia. It feels like that's what we were going for. And as a Georgia resident, I feel like even though I'm not a Georgia boy, I've lived in Georgia for a long time. So I love her and I get to critique her. Closing down spaces and, for a week or two when we have very little cases, and then opening them back up when we started to see a spike, for whatever reason, I don't want to get into any type of political space, was not the best idea for Georgia. And now we're seeing that Georgia is like one of the #1 places that you're likely to get coronavirus. And here's some of the places that are actually beginning to reach a tipping point around their ability to care for sick people. Their resources are becoming overwhelmed. Hancock, Gilmer, Newton, Cherokee, Gwinnett County, Clayton County, Bartow, and Polk. I mean, counties that are actually not that far from Atlanta. And then counties that are considered accelerated spread, like extreme hotspots. Fulton County, the county that I actually live in, Cobb County, DeKalb County, Forsyth, and Paulding counties. This is not a game. So like, this is what we're trying to impart to you. Just because things are open, just because there's a party going on, just because, clubs are open and things like that, and a meal is being served indoors, doesn't mean that the coronavirus is gone or that we're at the end of this virus. That was not conveyed in Dr. Chan's presentation. Next slide. Sporting events. If you're like me, you love sports. And, while I've been on hiatus from certain sports for the last couple of years, the idea of going to an event, going to like a sporting event or a concert or something like that is very attractive after, like Damon said, after physically distancing and being hankered down for so long, you want to go back and sit in the stands. But some places, your favorite team may or may not actually be allowing fans to be in the stands. And even if they are, I would base my decision as to whether to go on the prevalence or the rate of corona in that place, and still would probably consider not going, just depending on like my comfort level, because you may or may not get corona, but then the threat of it or feeling like you may have put yourself at risk for something that you could do when corona is not an issue might cause unnecessary angst. Next slide. So the part that we all want, the sexual health update. And as we can go to the next slide, we all wondered, like, is this safe to play? As Dr. Chan has presented earlier, that there have been there has been COVID detected in semen and fecal matter and things like that. But it's still not seen, or it's still not said to be a sexually transmitted disease. But that doesn't mean that we let down our guard and do just everything that we would do before, because you can still get COVID from a sexual space, right? Because COVID is spread from saliva. I don't know about your sex, but most of my sex, good sex, involves a bit of saliva, some mucus, breath, breathing hard, fecal matter even. So it's important that we are protecting ourselves and that we're assessing, our partner's health, our health, making sure that we're playing in the safest, most protective ways possible. Next slide. So what do we know and what don't we know? We know that the coronavirus is a novel virus, right? It's a new virus. We don't know much about it. We're hearing every day, it seems that we hear about some other lasting effect or it affecting a demographic or group like kids that we assumed or thought that it wouldn't. The virus, again, is spread through contact with saliva, mucus, breath, and things like that. We know that, again, it's been found in fecal matter as well as semen, but we don't know that those are spreaders. And we know that other coronaviruses do not spread through sexual contact, but having sex puts you in contact with a lot of the other, other spread modalities, right? So it puts you in contact with breath. It puts you in contact with, saliva. It puts you in contact with other bodily fluids and things like that. So it's best to just keep ourselves safe, and it's up to us to determine what safe is. And hopefully, if you've been attending these Stronger Together presentations, you're basing it off of the information that you're hearing here. Next slide. Okay, so this is the best way. These are the safest, less risky ways to engage sexually during this time. So your safest sexual partner during this time is yourself or somebody that you live with that you can verify is also physically distancing, like yourself, a monogamous partner, someone who is in the house with you. And if we can go to the next slide. We should try to, as best as possible, to limit like our sexual contact with people who we don't know or people who are outside of our homes. But if you're going to engage somebody outside of your home, let's pick people that we can trust. Like Damon spoke about having that quarantine bubble, that COVID crew, right? Of people that we can trust. Limit your sexual partners to people that you can verify are physically distancing, as well as yourself. Talk about COVID-19. Just like we're negotiating sex, we should be talking about other sexually transmitted diseases and ailments and things like that. Just like we talk about the things that we want to do during sex and how we want to get down, we should be talking about COVID-19 too. Have you experienced any of these symptoms? What was your travel like? When's the last time you kicked it on the beach in Miami? Things like that. And of course, it's hard to have these conversations. It's challenging to have these conversations, but just think about how vulnerable and open our sex usually is. It's worth it, right? Again, ask questions about contact as well as symptoms, and then also be honest about your risk factors, right? If you've gone to Florida, if you've gone to a place, if you live in a county where there's a lot of spread and you've maybe gone to a bar and stuff like that, let's normalize being open, just as open as we are when we're having sex, before we have sex, and have these conversations. Next slide. So take care during sex, right? Understand, the best sex is worry-free sex, right? So like if you're having sex with somebody outside of your home, and if you're a passionate person and you might be prone to kissing and wanting to kiss and rim and things like that, understanding that there's a level of risk there. You know, there's a level of risk for contracting COVID there. And if that is a thing that you're trying to avoid, maybe not French kissing on, you know, a person that you can't verify is physically distancing, or a person that doesn't live in your home. Maybe not, you know, and you know, tossing salad or performing, you know, rim jobs during this time. And then consider wearing masks during sex. And I know that sounds crazy, but like, you know, hey, I can think of at least 10 ways right now to make mask sex hot. If you can think of some ways too, don't put the ways, but say, yeah, I can think of some too in the chat box. Or even put the ways. Hey, next slide. Like I said, create ways to make, you know, this safe, you know, COVID safe, less risk mitigation sexy. You know, PPE role play, you know, don a mask and, you know, role play, make it fun, make it hot, you know, sexting, you know, talking about the things that you're gonna do and the things that you want to do. Some of those things that you probably can't do with a person that you're just meeting now, but talking about, like, you know, when we get tested together, when I know these are the things I'm going to do to you, and, you know, making it hot. Again, mutual masturbation is always hot. If you're like me, you like to see your partner get off. Understand though, there are rules of engagement to mutual masturbation. Understanding that COVID has been found in different bodily fluids, including semen as well as fecal matter. Not sharing, you know, dildos and anal insertive toys during this time. And if you are playing in a session that uses an insertive toys or any type of toys, making sure that you wash them before and after, especially if you're using them with somebody other than yourself. And assuring, like, if you're having, you know, virtual sex, or you're playing in an area that has like different surfaces, wipe those surfaces down, wipe your keyboard down, your computer area, and just let's keep it hot and sexy, but also safe and sanitized as well. Next. Okay, so like are single and you live in Atlanta and it's the summer and you're lonely and you've been having sex with people that you don't know very well. Don't judge yourself. It's not necessarily here. Don't freak yourself out. But these are some things that you can do, right? Closely monitor yourself for symptoms. You know, look at, you know, maybe choose to go on a self quarantine, or at least looking at yourself for symptoms and understanding what the symptoms of COVID are and how they feel and how they take place. And if you are feeling them, as a matter of public health, being polite in public health terms, don't put anybody else at risk. If you have a headache, if you have a fever, if you have a cough, don't hook up. Consider getting tested more often. I know myself, and, you know, I've been getting tested every 2 weeks just for my own mental well-being. I have an elderly mother, and I want to be able to engage with her. So to keep myself as well as my loved ones safe, I get tested every 2 weeks. Take precautions when interacting with people or at risk for severe COVID illness. Like I just spoke about my mom, right? Like, if I just hooked up, you know, we could go and I might feel fine, you know, but I'm not going to get up with my mom day 8 because I know that I could be pre-symptomatic or asymptomatic even. And I don't want to spread COVID to not only just my mom, to any of the people that I love and care for. And be vigilant about wearing your mask and and your hand health, you know, not only for yourself, but, you know, we may wear masks to help to avoid contracting or spreading the virus to anyone else. Just be considerate. You know, there are people who are hankered down still, who have been, you know, in the house since, you know, March, and they're doing the most that they can to keep themselves safe. And if we've let our guard down a little bit, and there's no judgment in that, that's our decision. So we have to keep our communities and everybody else safe, right? Next slide. And here's some practical advice for people living with HIV. If you're a person that is living with HIV, or any person that takes medications, period, during this time, make sure that you you have all of your medications on hand, at least 90 days of your medications if you can. Some providers' offices are allowing for that. Some medical providers are allowing you to get more medications. Understanding maybe, you know, always keeping your contact information for your your care team on you. I'm a proponent of having it in my phone. I text my providers. I ask them questions on the weekend, and I'm sure that they love that. So keep it on you, not only in your phone, but like if you can, keep a written down copy in your wallet, making sure that your care team, your care team, but as well as your emergency contacts, so if you are hospitalized, people have a way to let the people who love you know. And again, keep this information not only in written down, but keep it in your phone as well. Sometimes you might get it separated from your wallet or your phone, and that way you have it either way. Next. And this is a discussion guide right here. I love this guide from Thera Technologies. It helps us to become more comfortable as people living with HIV, talking and having these conversations with our providers. It reminds us of, okay, like, what is your CD4 cell? What is your CD4 count? Do you know what a CD4 is? These are some practical questions that you can ask your doctor so that we don't feel like, the doctor's in the driver's seat and we're in the back seat or we're in the passenger seat. This is our health and this is our life. We should be in the driver's seat. So definitely check out this discussion guide. And the next slide. We want to thank you for coming and showing up for not only this conversation, but for all of the conversations that we've had. We love convening this space for you all, and we look forward to hearing your questions. If you want to reach out to any of the Thera team, here's their information. And again, we're opening it up to your questions and answers. Oh, do not forget to do your evaluation. You could have the chance to win a $100 gift card. If you don't want the gift card, do the evaluation. You can just send it to me. I'll put my contact information in the chat. Next. All right.
Okay, thank you all so much for this awesome presentation today. If I could have all of the panelists turn on your cameras for the question and answer session. Okay, so the first question we have is for Dr. Chan. What changes have you seen regarding the susceptibility of transmission among school-age children?
Yeah, this was this was definitely a question there. There was a study. I couldn't find the original data, but there was definitely a widely circulated idea that for whatever reason, children did not transmit the virus. And unfortunately, what we've seen, there have been a couple critical outbreaks. Most notably at an overnight camp in Georgia, Zabaluski et al., that demonstrated that children most likely spread pretty much at a similar rate to adults. And so unfortunately, this was a huge part of the debate in terms of whether or not to open up schools. I mean, I certainly don't want to be the person to make those decisions. But the reality is that school-age children unfortunately are most likely able to spread the virus at similar rates to adults.
Thank you. Another question for you, Dr. Chan. Is it that more older people have comorbidities, or is COVID attacking those that are older?
Oh, yeah, I saw that question pop up in the chat. That's a really great question. I think what we've seen is that when controlling, because we have more data for this, when controlling for comorbidities as best that we can on a statistical modeling side, older folks still have increased morbidity and mortality. There are a lot of different theories for this. It's kind of two different arguments. Like one is the immunosenescence argument that as we get older, our immune system, kind of gets more lax and chilled out. But the counter to that is that these folks don't have overwhelming levels of virus, overwhelming viremia. It's possible that they have some kind of, inappropriate immune response that ultimately leads to, mortality. So I don't have a specific answer, but to your question, this is controlling for comorbidities. Certainly, I agree with you that elderly folks do have more comorbidities, but those are all additive. If you're elderly on your own, unfortunately, that's enough.
Thank you. And this was a comment, I believe this was during your section, Larry. that I thought was just really interesting. It says, the feeling of being torn you were just describing has brought me back to June. I went to a Black Lives Matter rally in my hometown with 10,000 participants. My husband told me to quarantine myself away from him and our 3-year-old daughter, which I did. I stayed elsewhere for 4 days and got a negative test. But it was so hurtful. It felt like he was shaming me for standing up for something I believe in, for our basic human rights as POCs. The hurt, the struggle, and confusion has been so real.
Ashe, I totally feel you. When I saw the racial unrest happening, it really like broke my heart because hearing that like, Black people were dying at this rate, hearing that, upwards of over 30,000 Black people have died thus far, really just, it's alarming and shocking to me. But you like we said, you have to like Damon so eloquently pointed out, you have to choose for ourselves like what matters to us, and then and I understand your husband's point too, like like we have to understand like, okay, so what after the decision looks like. So like I made the decision to go to Melbourne, Florida 2 weeks ago because I needed I needed to get away. I researched the place. It had very few cases, but when I got back, because I got on a plane, had I watched Dr. Chan's presentation, I probably wouldn't have gotten on that plane. But I got on that plane anyways. And when I got back, I'm like, okay, I'm gonna get tested. I'm gonna chill out, just because we have to think about the other people in our lives. Like, I appreciate you, and I definitely salute you for actually showing up for us, because as a Black man myself, and as a person who studied African American studies and considers himself to be very pro-Black, I could not bring it myself to even go to the space, not even to hand out, hand sanitizer and masks. So thank you for that. And thank you for what you do and showing up for us.
Yes, thank you. I don't see any other questions in the chat box. So I believe that is all.
Thank you all for joining us. Thank you, Thera and ADTC. Love you all.
Thank you.